Astellas is derived from the Greek word aster, the Latin word stella, and the English word stellar, all meaning star. We constantly pursue cutting-edge science and have produced results in the fields of urology, immunosuppression after organ transplantation, and oncology. As a result, we have contributed toward improving the health of people around the world. We are pioneers, constantly searching for innovative healthcare solutions that tackle diseases where no effective treatment options exist or existing treatment methods are insufficient. We believe these solutions are the keys that can unlock healthy lives for patients. We are committed to discovering fundamental cures for our patients through research and development in next-generation therapeutics, such as cell therapy and gene therapy. Alongside our many global partners who share our ambition, we will continue rising to the challenge of bringing new treatment options that make tomorrow shine. Astellas will continue to pursue cutting-edge science to deliver innovative treatments for patients. On the forefront of healthcare change to turn innovative science into value for patients.
Expert inside Salon. This is the GU Oncology Symposium. So I'm Dr. Guru Sonpavde. I'm the GU Oncology and the Phase 1 clinical research leader at the AdventHealth Cancer Institute in Orlando, Florida. And I'm the chair, and my China co-chairs are Dr. Bin Hu and Dr. Shengjing Chen. And as you can see, they're from Liaoning Cancer Hospital for Dr. Hu and the Sun Yat-sen University for Dr. Chen. So the agenda is as follows. So I will have some opening remarks, what to expect in GU Oncology at the 2025 ESMO annual meeting. And then we will have a keynote speech on the new data from EV303 trial, which is a landmark trial for us in this setting by Dr. Alexander Fehr. And then we will have expert commentary on this EV303 trial from Dr. Robert Jones. And then we will have a discussion of all of the panelists, including especially a perspective from the point of view of China. And then we will have closing remarks from Dr. Bin Hu and Shengjing Chen. So first I introduce Dr. Alexander Fehr from the Department of Urology from Magdeburg, Germany, to give us the discussion on the EV303 trial. Dr. Fehr.
Thank you very much. So everybody, it's an honor for me to be here to this international perspective on this really practice-changing data. As mentioned before, I'm from a university hospital in Magdeburg in Germany, and it's an honor for me to give a keynote speech regarding the data from the EV303 trial that has been presented yesterday. So here are some disclosures. And to start, I just wanted to give you a short overview about the things that happened in the landscape of muscle-invasive bladder cancer. And what we did see is cisplatin-based neoadjuvant chemotherapy was already introduced in the 1980s and having a clinical meaningful survival benefit of about 5%. And cisplatin-based neoadjuvant chemo followed by radical cystectomy has been and is now the standard of care for cisplatin-eligible patients with muscle-invasive bladder cancer. There have been some new things in the last years that changed the landscape. In this year, there has been the approval of perioperative durvalumab in the setting of perioperative strategy in muscle-invasive bladder cancer. And but while many things have changed in the landscape for patients who can receive cisplatin, we have another big unmet need for some options beyond radical cystectomy in patients who are not able to receive cisplatin. So this is what happened in about the last 10 years, at least in Europe and America. And as you see, with, the last years there has been either neoadjuvant systemic therapy or adjuvant systemic therapy. And what's new in the actual trials that are the data will come out this year and next year's is like we have like a perioperative approach. So we have neoadjuvant and adjuvant therapy, with radical cystectomy being a bit still the standard of care for the patients. And if you check the NCCN guidelines, we see that where the patient is fit, a candidate for cystectomy, we see that up here there's a lot of things if the patient can receive cisplatin. So we have neoadjuvant therapy, the surgery, and then the adjuvant therapy, like cisplatin-based chemotherapy or nivolumab. But when we check here, and I will talk about that in detail, it's like patients who are not able to receive cisplatin, there is basically just the cystectomy as the standard of care, and maybe some adjuvant setting, but there's no approach to now with a new adjuvant systemic therapy. And what is the problem? Patients that are cisplatin ineligible, they have a poor prognosis for the disease, and those patients straightly proceed to surgery, and there are no alternative systemic therapies to cisplatin. And what I put down here is like the Galsky criteria we all know. This is like the clinical factors that decide if a patient can receive cisplatin. And what we have to be aware of, like 50% of patients with muscle-invasive bladder cancer are not able to receive cisplatin. So that's a huge number of patients. And here are the factors that can lead to cisplatin ineligibility. It's like the creatinine clearance less than 60 milliliter per minute, a hearing loss, a poor performance status, neuropathy of grade 2 or greater, and cardiac dysfunction defined by NYHA class 3 heart failure. So to summarize, we have a lot that we can offer right now to cisplatin eligible patients, but there's a huge unmet need for neoadjuvant and perioperative treatment options for patients who cannot receive cisplatin ineligible, which is, like I mentioned before, about 50% of all the patients we meet in our clinic. So, and this was the rationale for a lot of different trials. I put it together in this slide. So there are trials tackling the cisplatin ineligible patients and also cisplatin eligible. And we did see the good results from the Niagara trial in this year that led to the approval of this perioperative development and gemcitabine and cisplatin. And I'm really honored to talk about the data that has been presented yesterday, and that will be something that will change the landscape for our patients. So now we go on to the data. So the Keynote 905 or EV303 study is perioperative enfortumab vedotin plus pembrolizumab in participants with muscle-invasive bladder cancer who are cisplatin ineligible. And the data was presented yesterday by Christoph Fulsticke. And I want to give you a little bit about the background. So what is the rationale for this treatment? So till now, as I showed you before, there's no phase 3 trial that has shown benefit from perioperative therapy in cisplatin ineligible patients. And this group of patients tends to be older, more frail, and they have more comorbidities, especially cardiovascular. So these are basically patients that are more sick. And what's the rationale to try EV and Pembro in the perioperative setting is, we all know the amazing data from EV302 or Keynote 839 in the metastatic setting where EV Pembro did really, really well compared to chemotherapy. As I put here, we have like overall survival, which is about 2.5 years compared to 15 months in chemotherapy. So the rationale was very easy to get this further into the treatment algorithm in the perioperative setting. And now to take you through the study design, basically it's a phase 3 trial randomized. Patients were eligible if they had T2 or T4A, node negative and negative for distant metastasis, or node positive muscle-invasive bladder cancer. They had to be cisplatin ineligible per Galsky criteria, as I mentioned before, or they there was an option for patients to decline or refuse cisplatin therapy. ECOG performance status was 0 to 2, and they were randomized 1-to-1 into a control arm as a standard of care that was direct radical cystectomy with pelvic lymph node dissection, and the other arm did get 3 cycles of enfortumab vedotin, 1.25 milligrams per kilogram on day 8 and day 1, and 200 milligrams of pembrolizumab. So, and after the surgery, they did get 6 cycles of adjuvant, EV, and pembro. Primary endpoint was the event-free survival, and there were other key secondary endpoints like overall survival, pathological complete response, and there are some secondary endpoints like safety. And it's a modest-sized trial, I would say. So we have 170 patients in each arm. Here you can see how the disposition went. So 167 started the neoadjuvant phase in the test arm. 150 did undergo surgery, and 156 patients out of 174 in the control arm. And what we do see that after the surgery phase, 100 patients started the adjuvant phase. So this is about 2/3 of all patients did go, who underwent surgery, did go for the adjuvant phase. Due to the fact that nivolumab was approved for patients with MIBC and with a high risk of recurrence, during the roll-in, about 17% started adjuvant nivolumab as standard of care after the approval. So the baseline characteristic, they were very well balanced. We have indeed some, about 10 to 15% patients with ECOG2. The vast majority was, in fact, ineligible for cisplatin. So 4 out of 5 patients were cisplatin eligible. And we did have a lot of patients with a locally advanced T3 or T4A tumor stage. And what we did see is like the median age was about in the mid-70s, which is a lot higher when you compare it to other phase 3 trials like FESPA or Niagara. That has been about 65 to 69 years. So we see that this cisplatin ineligible cohort represents patients which are older and have more comorbidities. So that's a very important thing to keep in mind when we see the performance of a control arm. And here we see the really amazing data in event-free survival. So we see there's a hazard ratio from 0.4 favoring the EV pembro group, with a median is not reached yet. And what was an event? An event was a patient not undergoing surgery, metastases during the surgery, or gross residual disease, or what for most of the cases, a relapse with a local recurrence or metastatic disease after the surgery. So this is really, really impressive when we keep in mind that these patients cohort are really old and basically sick patients. This favoring of EV pembro was basically for all subgroups. I think if you really have a look at it, you can argue that patients who are cisplatin eligible but declined seem not to have a favor for EV pembro, but you have to keep in mind that this were only a very few patients in this cohort. So we have a very wide range in the confidence interval. So that's, in my mind, I wouldn't transfer that this EV and pembro regimen is not working in the cisplatin eligible cohort, but I think that's something we have to discuss afterwards. When we check for overall survival, we see again a really, really good result with a hazard ratio from 0.5. So after 2 years, 4 of 5 patients are still alive. whereas in the control group, just 3 or 5 people are still alive. So we see that this combination is really working really, really well, but we also see that patients who don't get any perioperative therapy do very poorly just by cystectomy alone. Also here we see the same, no difference in subgroups, so basically every patient is getting an advance when he is getting the combination. And that was something I was really, really impressed by as a pathological complete response. So we talk about patients who get perioperative therapy, they get a cystectomy, and in the specimen of a cystectomy, and nearly 60% didn't have any tumor in the bladder. So this is very, very impressive, and this is, to my mind, the highest PCR rate in any phase 3 trial we have seen in the setting. And if you have to think that more than half of the patients didn't have cancer in the bladder that was removed, we have to start thinking about bladder preservation strategies, because the patients will ask us if it was really necessary to remove the bladder. So we have to, this data really opens a window for some new perspective on this. Like in any trial, we have to see how the safety and the adverse events are going. So what we can see is there is, of course, there are more adverse events in the group that's getting EV pembro, because the other group didn't have any perioperative therapy. What we can say is there is no delay to surgery. As I go in detail on another slide, we see that in the surgery phase, in the cystectomy, there was no negative impact in the arm with EV pembro. And what we can see, there is some dose reduction of EV. Some patients, about 4 of 10 patients, did have a discontinuation of EV, and pembro was really good tolerated. So this is something that we know from a metastatic setting. So there's no new safety signal in this earlier landscape. So what we see is, like, we have to admit that there was 70% grade 3 or higher adverse events. That is something that we have to reconsider in this group of patients, which is they are more frail, as I mentioned before. They have more comorbidities. But what we do see, there's a lot of anemia, but that is something, in my mind, that's coming from the surgery phase. I think it's not really a great adverse event that's typically for EV. And we check on the surgery phase. So myself in Germany, I'm not a medical oncologist, but urologist. So I do by myself do some surgeries, some cystectomies. And for me, it's really important that this new regimen doesn't have any negative impact on the surgery phase. So this is something that as a surgeon, I'm most afraid of, if some neoadjuvant treatment is getting the patient not receiving the surgery. Special interest, we all know, I think, about the adverse events regarding to pembro and to EV. So what we do have, and especially EV, we have the skin reactions, especially early in the treatment. So that is something that could occur in the neoadjuvant phase. We have peripheral neuropathy, but it's a low grade here, grade 3 or higher, was less than 10%. And we have ocular disorders and hypoglycemia, but that is something that we are aware of from a metastatic setting. So this is not anything that we can't handle, in my mind. So to summarize and conclude, this is the first trial that shows a great benefit, in my mind, for event-free survival and overall survival in patients ineligible for cisplatin-based chemotherapy, or for patients that did refuse cisplatin based chemotherapy. There was no negative impact on the surgical phase. The safety profile was consistent with the profile we already know from a metastatic setting. And this indeed is the first phase 3 trial that shows improved efficacy outcomes with perioperative therapy with patients who don't have any good alternative in the disease. So this may represent a new standard of care And this is really addressing a high unmet clinical need that a lot of patients will do a lot better with this data. Just to give some limitations, as I mentioned before, there was just 17% got an adjuvant nivolumab, so this is something that would be a little bit higher, at least in Europe in my mind. We have this potential difference between cisplatin ineligible and refusing, but as I mentioned before, there's small numbers, so I think that's nothing that we should overinterpret. And the question is, if we think about what's coming after this time, if patients get a relapse and a metastatic disease, is there something that if EV-pembro would have been available in the metastatic setting, would the control arm have performed better? So we don't know that. Some points of discussion, just to give you something to talk about. It's a perioperative trial, so we don't know what if the neoadjuvant or the adjuvant phase is really the phase that's getting the big effect for the patients. I hope to see some biomarker analysis like ctDNA to get like a more approach of escalating or de-escalating the therapy for some patients. So the question is, if a patient is CT negative and has a pathological complete response, if this is a patient who should have the 6 cycles of adjuvant EV-pembro, or is it a patient that we can just observe and maybe do a regular ctDNA check or something like that and restart treatment when he's getting positive again? What would be the first-line treatment in case of recurrence? So now the standard, at least in Europe and USA, EVP is the standard in the metastatic setting. So if a patient already did have EVP perioperative, is that something that we could do like a re-challenge, or do we have to switch for another medication? And the big question in my mind is this data transferable into the cisplatin eligible population? But I think that's something that will be looked for in another trial. So for a personal conclusion is this will become a new standard of care in perioperative treatment of cisplatin ineligible patients with muscle-invasive bladder cancer. And this is really something that should change our practice when we go back on Monday or Tuesday, because ESMO is still going on. And so with a picture from Magdeburg, I'm very thankful and I'm looking forward for a discussion. Thank you very much.
Thank you, Dr. Fehr. And now I will invite Dr. Jones to give us a commentary on the EV-303 trial.
Thank you very much. So I'm a medical oncologist treating, among other things, urinary bladder cancer. I guess, thank you. First of all, it's been really exciting to be here in ESMO. It's been a fabulous ESMO. There's still more to come, more bladder data to come. Yeah. I think bladder's really taking the limelight in this meeting, and I'm really excited to be invited to come and give my early views on these data. I only saw them for the first time yesterday as well, so I may revise my view on this over time. So I want to try and put this trial into a bit of perspective, these are some disclosures. I'm going to divide this into 3 sort of areas. First of all, a little bit of commentary and a few cautions on the data, my sort of initial reactions, and then a few additional insights I want to add, maybe by putting it into a bit of perspective, and then briefly look into the future. And Dr. Fehr's already sort of alluded to the future for this. Before I start with my comments and cautions, this is clearly a groundbreaking trial, and we've yet again seen some knockout data for this combination of drugs, and anything I say after this does not detract from that. So we've seen this before. This is the key secondary endpoint of overall survival. In my mind, this is the key finding here. Yes, event-free survival is important, but actually, what we're trying to do here is cure patients. Okay, let's be really honest about this. And actually, this is probably the only opportunity we have to cure patients with drugs with bladder cancer. I don't think we cure anybody with a metastatic disease, but here, and these are the long-term follow-up data from the European neoadjuvant cisplatinum trial. Obviously, this is quite a historical trial now, but this was one of the two trials which really set the scene for combination cisplatin-based chemotherapy, obviously in the cisplatin eligible population. The only reason I'm putting this up is twofold. Firstly, this is the 8-year follow-up data, and you can see those curves are separated. They remain separated. This is as close to demonstrating cure as you're going to get in this setting. And so the first caution is, we haven't seen anything like this maturity of follow-up yet. This is just 26 months of follow-up. It's really important we do monitor these survival curves and ensure that they stay apart. I personally have little doubt that they will do that, but right now we have not shown that this is a cure. But I think it's my interpretation of this is that what we've seen so far says that if this translates through in the same way that it did in the BA06 trial, then we will be curing many more patients with bladder cancer. And that is, as a medical oncologist who spends most of my time giving drugs to help people live a little bit longer, that is really exciting. And the second caution is around numbers, again about maturity. And Dr. Fehr, you alluded to this. I think particularly we need to be really cautious about any interpretation of subgroup analyses. I think all we can really say at this stage is there are no outliers. And a lot of these ones, particularly ones with the broad confidence intervals, they're very small event rates. So, for example, you highlighted those eligible but declining. That's 21 events out of 63 people. So you know, there's less than a third of the patients have actually had that event. So I think we would expect to see these forest plots change quite significantly with follow-up. And the other thing that's been mentioned is that this trial was conducted before adjuvant nivolumab started to become standard of care, and the protocol was modified to allow adjuvant nivolumab when it did become available, but only 17% of patients in the control arm got adjuvant nivolumab. And so you could argue that actually the control arm of this trial was not the current gold standard of care. But this is some data we actually saw earlier in the ESMO meeting just on Friday. And this is the patients from the Checkmate 274 trial. So that's that pivotal trial of adjuvant nivolumab. And this is the group of patients who did not have prior cisplatinum, okay? So you had to be unsuitable for cisplatinum to go into this trial. Many of the patients, the reason they were unsuitable was because they'd already had it neoadjuvantly. But this is that group of patients who were both unsuitable at this point and had not been considered suitable for neoadjuvant cisplatinum before they went into the Checkmate 274 trial. And actually, without going into great detail, these patients don't do that well. And this is the all comers. This isn't just the PD-L1 positive population. This is the whole ITT population. So if you look at that overall survival on the right there, you know, the hazard ratio there is 0.7. It's good, but it cannot possibly explain what the difference between the Kaplan-Meier curves we're seeing in the EV304 trial, because you know some of the patients still got this treatment, and even if all the others had nivolumab, it can't possibly have explained the efficacy difference between the two arms of the trial we've just seen. So moving on, a little bit of additional insights. You highlighted the PathCR data, and I want to just put this in a little bit of context, because I think you're right. I think these are the most impressive PathCR data we've seen in a phase 3 trial. There've been some pretty impressive results in phase 2, where of course this is a key endpoint in phase 2 because it's an intermediate endpoint. I don't think PathCR by itself is the reason to give neoadjuvant chemotherapy. It's just that PathCR is probably quite a good surrogate of outcome. We've seen the outcomes, so the PathCR are somewhat secondary in this situation. But I want to just remind us why we're excited by PathCR, because these are data from the original SWOG trial of neoadjuvant MVAC. So I showed you there were two pivotal trials of platinum historically. There was the European BA06 trial that I showed you, and these are the US MVAC data. And at the bottom two curves there are the patients from both arms who did not have a PathCR, and you can see they both did equally badly. So in other words, if you had chemotherapy and you did not have a PathCR, then your outcomes were no better really than the patients who had no chemotherapy and did not have a PathCR. Conversely, if you had a PathCR at the time of cystectomy, then your outcomes are very much better. And you are, even if you didn't get chemotherapy, bearing in mind some patients have a path CR after the TURBT alone. It's a small percentage of patients, hence the big steps in the second curve down there. But conversely, if you have a path CR, however it's induced, whether it's with drugs or without, then the outcomes are very good. And these are the data from which you've already shown us from this trial. And again, the brown curve, that's the patients in the control arm who did have a path CR. There were very few patients there, so don't get too excited by the shape of that curve or the separation between the top two lines there, because it was a very small handful of patients in the control arm who had a path CR. And I just thought I'd rather cheekily align these curves, and I've truncated them so the scale bars are roughly similar. I was doing this late last night, and I think it's quite interesting that actually the early shape of both curves, both the non-path CR curve and the path CR curves, actually very, very similar. Now, that doesn't mean that these trials are very similar, because of course the excitement here is you're getting nearly 3 times as many people having a path CR, okay, with this treatment. But I guess what it does do is it does kind of support the idea that actually the objective here is to get a path CR, okay? And I don't think we should get too excited about the differences between about the effect of chemotherapy once you've had a path CR. And so this also reflects onto what you started to talk about a little bit there, Dr. Fehr, which is about, well, what is the value of the adjuvant phase? There's a lot of talk. The regulators in the US are very concerned about not being able to demonstrate the effects of the adjuvant. I think as a clinician, I'm not that bothered about it. The most exciting thing is we can give this to our patients, but we don't actually know whether you need to give this post-operative enfortumab vedotin and pembrolizumab. So let's remember, 3 cycles before and 6 cycles afterwards of the EV, and a year of pembrolizumab in total. And again, these are some data that we saw on Friday, again from Checkmate 274. This is the first time we've seen these data, and they're a little bit complicated on the slide there, but maybe if you look at the overall survival curves on the right, the top 2 dotted lines are patients who did not have detectable circulating tumor DNA at the time of randomization to nivolumab, for or against nivolumab. And you can see, if you didn't have circulating tumor DNA, the nivolumab makes precious little, if any, difference. So you could argue that if you have no circulating tumor DNA, you do not benefit from, and therefore do not need, adjuvant nivolumab. Whereas if you do have circulating tumor DNA, the thick lines, the bottom 2 thick lines there, first of all, you do worse. That's not a big surprise, but you do very much better with nivolumab than without. And so I think this does give us a real clue that we might rapidly move into a position where we can actually identify a group of patients who may not need the adjuvant phase of this treatment. We just have the neoadjuvant treatment. And we're going to see some more prospectively planned data tomorrow from the IMvigor11 trial, which may give us much more information about the value of path CR. And I think that may be possibly almost directly applicable to EV303. And then finally, a brief look into the future. The EV304 trial is fully accrued, and I understand we're going to get results from this trial in the very near future. And this, of course, I guess is kind of the golden ticket here, because this is patients who are suitable for cisplatin. So patients are randomized between standard of care cisgem versus EV pembro, followed by that adjuvant phase of EV pembro, as we've seen with EV303. So we are going to get an answer to this question: is it better than platinum-based chemotherapy, neoadjuvant chemotherapy in the platinum-fit population? And we're going to get that very soon. And I think the EV303 data really give us a strong indication of what we're going to see there. Be prepared for the hazard ratio to be a bit higher, because of course there is an active control arm here. But I think it should, this trial, if we can replicate what we've seen in EV303, we should quite easily beat GemCis in this trial. And finally, I wanted to just draw attention to a slide you showed earlier on, which is the NCCN guidelines, and I just put a red ring around the radiotherapy there. So a lot of patients want to keep their bladders. And And it's not actually just patients who are unsuitable for cystectomy who want to keep their bladders. And actually, the current way, we talk a lot about bladder preservation in not doing a cystectomy. The current way a lot of patients save their bladder is by having radical radiotherapy. And in the UK, we would give those patients neoadjuvant cisgem if they were suitable for cisplatinum but didn't want a cystectomy. And so how do we bring the power, and these patients still die from micrometastatic disease. So we need to think about how we can bring these tremendous improvements in systemic therapy to bear on this group of patients as well. Because I fear that these patients who do not wish a cystectomy may have an unnecessary barrier to optimum systemic therapy unless we do something about this. So in summary, thank you for listening. This is great news for bladder cancer patients, and it's a real prospect of curing more patients. You can forget everything else I've said. I think the mature data will provide more detail, but I agree we've got enough to act now. We don't need to wait for more mature data before we implement this trial. But we do need to start addressing the future barriers to getting all of our patients perioperative EVP, because I've highlighted one of them. There will be many others as well. Thank you.
Thank you, Dr. Jones. And now I want to hand over the moderation to Dr. Hu and Dr. Chen regarding the closing, regarding the discussion and the China perspective.
Thank you 非常感谢我们2位讲者给我们带来一个
Thank you very much to our 2 speakers for their really wonderful interpretations. Next part, we will have the panel discussion. We would like to invite our panelists.
2 speakers for your fantastic speeches. Now let's move on to the panel's discussion.
第一位呢是来自于我们中国的鲍一个教授，是来自于中国的华西医院。
The panelist is Professor Bao.
Professor Bao Yige. He's a urologist from Sichuan University, West China Hospital. Please, Dr. Bao.
Sure. Well, first of all, thanks for having me here. It's very exciting to be here, as well as we are excited about the result of EV03, as Dr. Fehr and Dr. Jones just mentioned. I think it's a revolutionary data. It's definitely going to change our daily practice in the future, without doubt. And also, I mean, what I'm the most impressed is the idea or the philosophy of combining the neoadjuvant and the adjuvant component together to do a salvage perioperative treatment. And we usually, back in the time, we were discussing about, the neoadjuvant versus adjuvant, which one may be better. And maybe in the future, there's not going to be these kind of questions anymore. And I have a few questions for 2 of the professors, Dr. Fehr. So, I mean, for me, one of the interesting things about the design of the trial is that in the control arms, they still use the neoadjuvant chemotherapy with the carboplatin-based neoadjuvant treatment as the control arm. So as far as I know, for those cisplatin-ineligible patients, we don't really have a standard of care of using, routine carboplatin-based neoadjuvant treatment for every patient. And, given the fact that the pass CR rate is only 7% for those kind of persons, you could really say that those neoadjuvant treatment is really helping. If you're looking at the, the neoadjuvant treatment for the prostate cancer is about 7 to 8%. The neoadjuvant treatment for the RCC is about 7 to 8%. And you don't really routinely recommend it. Neoadjuvant treatment. So I was wondering if those patients do upfront radical cystectomy, maybe plus and PD-1 adjuvant treatment, would the control arm generate better responses, what do you say?
Yeah, that's a good question. So the PASCR rate, like Professor Jones said, the 7-8%, we don't really know where it's coming from. So maybe you just got all the tumor out in some cases. The carboplatin thing, so I don't know, it's done in China or it's in Germany. If a patient is not eligible for cisplatin, we won't give him any other platinum-based chemotherapy because there's no really benefit for the patients, and they do better when you do a cystectomy in a short amount of time. So I'm not really sure if it could work if you do, like, as you mentioned, like a new adjuvant IO therapy or something like that. So that is something that could have done a little bit better, but I think you have to already check like some surrogate parameters, like if it's PD-L1 positive or negative. So, but I think this is the good thing of a study, that this is really the unmet need that we see every day in our practice, right? So this is how the patients are the patients are coming. Are you fit enough for cisplatin? Yes or no? If yes, you're gonna get it. If no, you get directly to surgery. So it's like more like a gut feeling, but as Professor John said, the adjuvant nivolumab cannot be the key thing that's bringing the curves closer together. So I think the control arm does do poorly. That's all right. But I think till now, this is the case where the patients are. So this is a realistic view in my mind. Yeah.
Yeah, exactly. I mean, plus the experimental arm has been done good enough. Like we all know about that.
Yeah.
Right? So, Dr. Jones, you mentioned a very interesting point. Past CR, no matter it's induced by TURBT or the systemic therapy, would both yield good prognosis. But I was wondering, do you think that different PCR induced by different things, say TURBT or the systemic therapy, is going to have the different prognosis? I mean, one thing is the strengthened maximal local therapy, but there's no prevention for the distal mass. Another one, systemic therapy, it has probably better control with the deep layer or the lymph nodes. Do you think like that's going to be a different things? And second quick question is about I would be curious about when will I use the immunocheckpoint inhibitor for the full course of bladder cancer patients? Neoadjuvant, like the EV03, or we'll just leave it to the adjuvant setting, or I should leave it until the metastatic settings, maybe combined with the chemotherapy. So which one should I combine, chemotherapy in the metastatic setting or a neoadjuvant setting, or I should just combine everything with ICIs, all the stages?
So I'll maybe take that bit first, and you might have to remind me of the first question. So I think, I think there is something special about combining EV with immunotherapy. Okay, we don't know which components. I suspect it's the monomethylauristatin E combined with any immune checkpoint inhibitor, to be perfectly honest, but it does look like it's better than the sum of its parts. And of course, the evidence for that really comes from the EV302 trial, where you're getting that duration of response. The duration of response there is the same as it is for monoagent pembrolizumab, okay? Except again, you've got 3 times as many people who are responding. So you definitely do not want to miss your IO out when you're combining it with EV, okay? So I think that's an absolute. I think that's the easy answer to your question. And I suppose having done that, you're limited in where you might use it in the future. I've said what I've said about the adjuvant, about the adjuvant component. It's kind of a really nice problem to have, to be arguing about whether or not you need the adjuvant component, and we can work that out over time. That's not the urgency. The urgency is getting the patients this treatment, to be honest. I mean, then the interesting question, which of course we've been asking for a long time, is, well, what's the role of re-challenge? What do you do when these patients fail? Do you give them chemo, and then do you give them maintenance of avelumab? I mean, I don't know. And I think it's going to be very nuanced, and we're probably never going to have really high-level data to answer that. And we're probably going to have to be, we're probably going to have to use our judgment, and it will depend on the patient characteristics. When did they relapse? What were they on when they relapsed, etc. Yeah, it's an interesting question, but the key answer here is that these data really shows you've got to have a combination immunotherapy at the start. You were asking about carboplatin-based combinations. There's a lot of studies of platinum combinations with immunotherapy, and with the possible, with some minor exceptions, they've all been pretty disappointing, and certainly nothing looks anything like as active as EVP. So I can't see a future for going back there. Obviously, we have seen the the Niagara data, which brings me back to your first question, which is what is the difference between a path CR with drugs versus a path CR without drugs, and what is the difference of a path CR on immunotherapy and a path CR induced by chemotherapy? And I think prior to yesterday, I was losing faith in path CR because I don't think path CR is a particularly good surrogate of overall survival. Yeah. And we certainly shouldn't be making practice changes based purely on path CR. But it is still enticing that we're seeing very similar outcomes. But we did from the Niagara trial, if you remember, that was because, of course, all the patients had neoadjuvant chemotherapy there. So it was interesting that the adding in the durvalumab did seem to make a difference to both the patients who did and the patients who did not have a path CR. So it does imply that there is something that the drugs are doing over and above inducing path CR. Okay, thanks.
好，我们第二位有请来自于中国医科大学附属生经医院的蔡伟聪教授。
Professor Cai Weicong from Shengjing Hospital.
Please allow us to invite Professor Cai Weisong from China Medical University. She's an oncologist, so please, Dr. Cai.
To invite me here to do the discussion and make comments. And the EV303 trial was the first time the audience seen the data, and it was presented with a subset analysis of those who got EV plus pembro versus just a pembro monotherapy perioperatively. And I think overall the data are very compelling in sort of the scheme of perioperative treatment. And that the clapping continued for a long time in the hall after the speaker presented the data. It's very exciting. And in older cisplatin ineligible or refusing patient population that has a ratio of 0.4 to 0.5 for EFS and OS are very remarkable. And I think for the, of course, the perioperative treatment, including neoadjuvant therapy, will enrich for those who don't receive neoadjuvant therapy because they don't have the benefit of neoadjuvant downstaging. And they seldom get the PCR PCR rate, PCR chance like Robert just mentioned. I think the field is really moving towards perioperative therapy, neoadjuvant followed by adjuvant, and not just a pure adjuvant. And we are hoping that uptake of perioperative therapy improves clinically. A combination of immunotherapy and ADC could be and should be a standard treatment regimen for MIBC patients. And we are expecting more data of cisplatin eligible patients treated with EV plus pembro perioperatively in recent future. And I'm really interested in how we select the right ADC drug, like HER2 positive patients. Could we use Nectin-4 antibody-directed ADC or HER2 antibody-directed ADC? So could you guys give me any advice on those?
I will just comment on it, but we're waiting for the phase 3 trial to read out, and it's being presented soon today at the ESMO Congress, which is comparing the combination of disitamab vedotin plus toripalimab versus gemcitabine platinum in HER2 expression by IHC criteria. So we have to see how the DV plus toripalimab compares. It's again across different studies. We have to see how good it looks versus EV pembro. This is an indirect comparison, not perfect, of course. So we have to see that and make up our mind. So we'll see. It's very interesting. At the moment, it's very difficult to say. I believe that the vast majority of patients have at least 1+ HER2 expression, but some patients don't. So are those the patients who should get EV pembro? I think that's something to look at. But the key is how good does this phase 3 trial look for DV plus toripalimab. So we need to wait a little bit and see.
May I comment on that? Because I think we certainly can't assume that all ADCs are the same here. I think it is reasonable to assume that all immune checkpoint inhibitors are similar. But what data we have seen, remember, we have seen that neoadjuvant phase 2 of toripalimab DV already, which were very encouraging. But again, like previous comments about PathCR. There is a suggestion that it's the payload that's maybe more important than the antibody target. And so I think we should be very cautious before assuming that any antibody drug conjugate has the same magic in combination with the immune checkpoint inhibitor, because the data we've seen for the non-MMAE conjugate has not been quite as impressive.
Okay, thank you.
Okay, let's the next discussion topic. Here is 3 discussion topic. The first one, which of the data from EV303 do you find most impressive and the greatest impact for clinical practice, and why? And the second, how do you see the EV303 regimen can be help MIBC patients have better clinical outcome? What unmet treatment needs can be addressed? The third, how do you think the EV303 regimen can be best embedded into clinical practice after it is approved? We still 2 professors to join us to discuss. The next one is Professor Jiwei Huang from Renji Hospital, Shanghai Jiaotong University School of Medicine.
Yeah, so it's very exciting to invite it here and listen to the EV303 clinical trial. So what's impressed me most is the very high PCR rate. So as the PCR rate is so high, so it means that maybe about 50% of the patients after the preoperative combination therapy, it be cured. And so can we select who will preserve the organ of the bladder? So how can we decide, maybe do a ratio RBT or just using the ctDNA or UTDNA? How can you comment this? So this is my question.
Can I comment on that?
Yeah,
I can comment on that. Basically, I think at the moment, I feel that to decide whether the patient can preserve the bladder and omit all local therapy, so no cystectomy, no radiation, I think that is not ready for prime time. I think it needs further study. We know that clinical CR is not equal to pathologic CR. This has been proven again and again. It's prognostic, but they're not equivalent. So in my mind, I think that to omit both radiation and cystectomy is not a good idea. At the moment, we have data in the radical cystectomy situation. I think we need more data in the radiation situation, but I would not omit all therapy, omit cystectomy and radiation both. At the moment, we only have data for systemic therapy plus the local therapy with radical cystectomy in this trial.
May I comment on that? So I think, as you mentioned before, so PathCR is not a very good or a perfect surrogate, but I think it's one piece of a puzzle. So we have we have PathCR. I hope to see some biomarkers as circulating tumor DNA. So if I have a patient who had PathCR and does not have tumor DNA detected after the neoadjuvant phase, so this is one patient that I would maybe give him a shot. So maybe you should say, yeah, so maybe they're not doing anything locally. But I think that we have to remind that even if it's just locally confined bladder cancer, there are a lot of patients, at least in my mind, and other colleagues like Dr. Jones was already telling, this is like basically a micrometastatic disease, right? So it's not just locally confined, but there is some DNA or some tumor cells in the body. And what we did see in the Niagara trial is that cystectomy did improve ctDNA clearance by about 10 to 15%. So the cystectomy is a crucial part till now in those trials. But yeah, I think this opens the door for 10 years ago, something like we don't have to do cystectomy was like a dream, no? And now we have to think about it. Is it possible? But we don't really know how to do the follow-up in the bladder, like you QRB, do we have an MRI of the bladder, ctDNA measurement on a regular basis. So we don't have really a protocol for that. But I think that needs further studies. But I think now there is a time where we can think about it and have a good rationale to set up trials. That has been a really long time coming. So.
Okay. Next join us discussion is Professor Wang from the second Shanghai Hospital of Central South University. Yeah, please.
Okay, thank you. I'm so glad to hear and to witness the release of the EV-303 study data. And I think this study will change the treatment landscape of MIBC and providing more the treatment options for cisplatin ineligible patients. And what I interesting, the first one is the bladder sparing treatment also, because I'm oncologist and also I'm a radio therapist. So I think this study gave me more idea. The PCR rate is very, very high. So I think in the future, TMT also a standard treatment for these patients don't want to cut their bladder. So in the future, I think we can add more treatment option to TMT, this kind of treatment options. In my recent study and my research is about bladder sparing treatment with the TMT combined with immunotherapy. And I have a real world study and very exciting result. So I think in the future, we can add the ADC drugs to TMT to radiotherapy for these patients don't want to cut their blood. And the second thing I'm very interested in is the future. Some patient is received ADC and he experienced disease progression and how to choose the next treatment. Use other ADC because in China we have DV. We can choose DV or choose SG or choose chemotherapy. I think in the future we should explore this area. That's my opinion. Thank you.
Okay, I can make a comment regarding DV after EV or vice versa. I think we will run into some neuropathy problem, but that is something to look at. So because the real drug in that is the tubulin toxin, MMAE, there could be some activity, of course, but I think this needs to be explored further. Maybe a different payload in the US. At least we have a TDXD, trastuzumab deruxtecan, available for HER2 3+. That has a different payload. So topoisomerase 1 inhibitor. But I agree the DV could play a role in some patients, but we have to be careful about the neuropathy and the cross-resistance.
Thank you. But the important thing is the sequence. Which one is first is the better, but now we don't know. The first is EV or the first treatment is DV. Which one? The first, second, third? I think that's the important problem.
Well, I think so. I agree that these are really interesting questions about what we do next. And that's, again, it's a really exciting problem to have, not knowing what to do next. But what we must not do is not give the best treatment first because we're worried about not having it later. We have to go with the data that we've got, which is right now is that EVP is clearly better than anything we've seen before for this group of patients. And we have to worry about what happens when they relapse later. We will learn lots more. We're going to learn much more about DVT this afternoon in metastatic disease, and all that knowledge we can bring forward and design clever trials to find out who should get DVT rather than EVP, for example. But that has to be done in a controlled way. We have to use the evidence that we've gotten out to do the very best for our patients, and it's that first shot, whether that's first treatment in metastatic disease or whether it's first treatment in the perioperative setting. All the evidence shows that that's the time to get the most benefits in it.
Okay.
Any comment, Edison?
I think I can have nothing to add. I think that what you have to do is, like Professor Jones said, now we have a chance to think about giving the patient a subsequent therapy, right? We had times where we did at least get one therapy and they were not eligible for any other therapy. So, but as Professor Jones said, I think it's important where we have most robust data, where we have the biggest OS benefit. That's the thing that we should do first. And then we can go do a biomarker selection or HER2 positive status, something like that. But there will be, in my mind, very interesting trials where we can see the subsequent therapies, how we're performing. But I would totally go with Professor Jones and tell the patient we have to go with a combination where we have the best data yet. And this is, in my mind, EVP by far, I have to say.
Okay. No more comment. The time is fast quickly. Now we move to our close remark. Okay. Today's exchange were active and practice. This session was high quality and high standards. My CCFS Professor Guru Sonpavde, Professor Alexander Fehr, Professor Robert Jones, Professor Hu Bing, and all colleagues on site and online. This symposium has successfully concluded. Thank you all.
Astellas is derived from the Greek word aster, the Latin word stella, and the English word stellar, all meaning star. We constantly pursue cutting-edge science and have produced results in the fields of urology, immunosuppression after organ transplantation, and oncology. As a result, we have contributed toward improving the health of people around the world. We are pioneers, constantly searching for innovative healthcare solutions that tackle diseases where no effective treatment options exist or existing treatment methods are insufficient. We believe these solutions are the keys that can unlock healthy lives for patients. We are committed to discovering fundamental cures for our patients through research and development in next-generation therapeutics, such as cell therapy and gene therapy. Alongside our many global partners who share our ambition, we will continue rising to the challenge of bringing new treatment options that make tomorrow shine. Astellas will continue to pursue cutting-edge science to deliver innovative treatments for patients. On the forefront of healthcare change to turn innovative science into value for patients.